Good afternoon, everyone. Thank you for being here. My name is Brendan Coleman. I'm a staff attorney with the Michigan Department of Civil Rights. I am a white man, short brown hair, wearing a blue suit and glasses. I have the distinct pleasure of welcoming you all to the Accessible Healthcare Workshop. This session will discuss how all individuals, including those with disabilities, can readily obtain necessary health services with minimal barriers. Before we get started, we have some housekeeping items. There are ASL interpreters and CART services in every session. If you have communication issues during this session, please let us know. Please identify your name before speaking. For example, I'll say this is Brendan speaking. The first rows of seating are reserved for close vision and fragrance-free seating. If you wish to comment or pose a question, we have note cards on each table to submit questions and staff to collect. If you prefer to comment individually, please indicate so and wait for a microphone to be brought to you or to an interpreter. The session will last approximately 1 hour and 15 minutes, and after the session, please return to the main plenary room for closing remarks in the session. Thank you all for being here. I'd first like to start by introducing the panel. We have Dr. Michael McKee, the Associate Director of the U of M Center for Disability Health and Wellness, as well as the Director of M Disability. We also have Robin Jones from the Great Lakes ADA Center, Michelle Roberts, Executive Director from Disability Rights Michigan, and lastly, Representative Sharon MacDonell. The full bio of all of our panelists can be found by downloading the Whova app or by using the QR code at the registration. Before we get started, we do have a few ground rules. I imagine we won't break them, but please keep the discussions focused on the workshop topic, specifically the broader policy implications of the discussion. We would like to end this session with 2 to 3 specific policy recommendations to promote accessible healthcare for all. We are unable to address individual complaints or circumstances in this session. There will be time allotted for Q&A at the close of the session. We welcome all comments with potential solutions for the issues being discussed. As mentioned earlier, there are no cards available on your tables for questions. Inappropriate, inflammatory, or disrespectful behavior or language will not be tolerated. Those in violation of this requirement will be warned once and then asked to leave. We're going to start our discussion of accessible healthcare by hearing from Dr. Michael McKee, who's going to talk to us about effective communication. Dr. McKee, what are some of the real world scenarios you have seen pertaining to accessible healthcare and effective communication?
Thank you. Hello, everyone. My name is Mike McKee. I'm a deaf family practitioner at University of Michigan. I identify as a white middle-aged male with glasses, short hair, and a white shirt with a tie. So I want to share, a patient scenario, unfortunate scenario that we see rather often in the medical field. So envision you have a deaf, hard of hearing, deaf blind patient reaching out to the primary care physician for an appointment. Maybe they call through VRS or video phone. Either way, they reach out, they make an appointment, they do notify staff that they're deaf or hard of hearing, and they request an accommodation, maybe an interpreter. And usually that encounter is a little awkward. Maybe they don't know what to do, but they agree, and that person will show up to the appointment. And it's often that the interpreter is not present and there are no accommodations given. And so now we're at a standstill. Maybe that individual is sick. Maybe they don't know what to do. And so what tends to happen is they move forward with writing back and forth or maybe some other strategy. And really, that person, the individual, they might feel disheartened, disappointed. They've gone through this frustration over and over, and that's a systematic experience that we see often within this field. There was a study that showed primary care physicians interacting with deaf patients are pretty. What would we assume that the percentage of primary care physicians provide an interpreter at their appointments for their deaf patients? Can anybody guess the percentage? 40%. Okay, it's 17%. 17%. So imagine if you were in another country and you didn't have an accommodation for your language and there was a communication breakdown. How do you expect to get any type of care in those situations? It's definitely not equitable. The trust is lost in those situations. You feel like you can't build a rapport with your doctor, you can't build a relationship. It's that we have patient-centered care that has been lost. The deaf, the hard of hearing, deafblind community struggle in these situations, and that impacts healthcare in general. If you can't connect with your physician, then what do? They tend to go to the emergency room at the main hospital. There are studies that show that our clients are twice as likely to go to the ER. Currently, we have no data that shows accommodation for hearing loss and deaf individuals. We have some hearing loss or late deaf individual. Oh, sorry. Let me pause 1 second here. I'm sorry. I'm gonna interrupt. I'm sorry. I see two people signing on the. I see Yeah, I'm having a hard time seeing here on the screen because it shows double. You're double. Do you want me to move? Is this better? Okay, perfect. Okay, great. So this is a perfect example. Oh, nope, we're back here again. Okay, sorry. Can I move and we eliminate the background here? Is this okay? Okay. All right, thank you. All right, so this is a perfect example. We don't know everybody's accommodation needs, right? Whether or not that person is late deafened or hard of hearing, we don't know how often they're given accommodations. We don't have data that shows that across the US. This is just another example of the fact that we need data collection. Are we providing good accommodations or not? Now, back to reference, the situation I was explaining is really just to help us establish strategies to move forward. Patient relationships are valuable. We really rely on patient centered care, and it's very important for us to help the patient learn their health needs. For example, if we have a patient who's diabetic, there's a lot to learn with that: what to eat, how to take care of themselves, if they need to exercise, their medication lists. There's a lot that's required, and who's teaching that? It comes from the doctors, the nutritionists, different physicians. Without interpreters, without communication, then there's a breakdown there. The knowledge gap is very large. So again, with disabled people, there's many that they're unaware of their healthcare needs because they don't have communication access, and the respect is lost as well. So it's really important that we hear from the patients. We hear what their disability needs are, what are their language preferences, and we can have that documented and have that established moving forward. And I'll explain a little bit more with the next question.
Work from here. Uh, how can healthcare providers advocate for their patients with disabilities better?
Great. That's a good question. So, just referencing healthcare providers, doctors, PAs, NPs, therapists, psychologists, just as a whole, healthcare providers. So, I'm not speaking specifically to one, but the healthcare team, it's crucial that they ask. And what I mean by that, like at the University of Michigan, we have established a protocol where we have a disability question. And we ask all of our patients, do you have a disability? They say yes. We ask which disability, and we have a list of those, and we can mark those off. For example, if they're deaf, then you have options which accommodation is best for that individual. And the goal of this is because the doctors tend to be unaware of the situations and how can they go into the room and actually provide an accommodation. So we have to collect that information first, and we have these standard questions established so that we can document that in their medical records and have it moving forward. And I'm using U of M as an example because we've established that there. And the second part is training. The healthcare team has no training with this. And I asked this question this morning to the morning group. If we're referencing medical students, for example, on average, how many hours do you think that they receive in disability health training? Now, understand medical school is a 4-year program, right? So I see a zero over here. Any other guesses? 2 hours, 5 hours? The average is 0 to 8. And we almost 1 in 4 people have a disability. And medical school really teaches minimally to this. And we need to require mandatory training. Students now are passionate about this. They want to learn about disability health. They want that requirement. And I really applaud them. I'm optimistic for the future. And with the University of Michigan, we have plenty of different courses that touch on disability health that we can provide. And we're hoping that this is a model that can be pushed forward at other healthcare facilities. We have the AAMC, which is the credentialing medical school for doctors. We have the ACGME, which is the credentialing medical school for residents and fellowships. And really, both need to require disability training. Right now, within the residency and fellowship program, we don't have a requirement. With family medicine, we don't have a requirement. There's no standard being set, but both organizations are hopeful. We're trying to move forward in mandatory training towards disability health. The third thing I'll mention is with students and student doctors, doctors in general, it's their legal obligation, right? That does overlap with training, but it's important to understand that doctors and the healthcare team want to help you, right? They just don't know how. They might feel awkward. Sometimes they might move to being hands off, and then it causes you to find another doctor. And so they really do want to help. So those are my 3 tips. And one more thing, just one more thing to add. I forgot to put this down. And we need your help, right? We need a centered resource page, which means all the training programs, all these tables out here. Doctors aren't aware of these resources. Maybe some social workers aren't aware of these resources. And so we need something that's easily accessible for the healthcare team so they can provide these resources. Okay, sorry. All right, thank you.
Brendan speaking. How can patients and their caregivers get involved to help healthcare teams do a better job?
It's also a good question. Patients and caregivers, how can they help impact the healthcare process? Really, they're key because they become the educators, right? Often you guys are the experts. Currently at University of Michigan, we're trying to recruit you guys, trying to get you to come, present, sit on a panel, be part of a discussion so that we can set up standard patient education, such as mock situations where you're sitting in these scenarios, so that students themselves can learn from you. Model through how do I work with a deafblind consumer? How do I work with a deaf patient, somebody in a wheelchair, or somebody with an intellectual disability? It really helps break the ice, right? It's okay if it's uncomfortable because once you work through that, the next time it will be comfortable. We also want to know what the disability is and the accommodation so that our medical staff knows what that looks like. Is that an interpreter? Is it Braille? Other resources that could be provided? Do they need transfer support from their wheelchair to the table? Right? It's required of our medical staff to learn these things. And who's teaching them? You guys, right? And so that partnership with the community, with you all, is really important with our medical staff and really helps when you guys become the educators. Additionally, if you see something wrong, don't tolerate it. File a complaint. Sometimes it's a simple teaching moment that this is wrong and speak up for yourself. It's important that you're advocating. And support groups are an additional area, maybe on Facebook or other social media avenues, where you can share your experience with those doctors, and sometimes they can look at those experiences and learn. They might be timid, they might be nervous, so they can work through those situations. Oh, do we have a question here? Do you want to wait till the end, or
Are we able to get a microphone up?
I think we'll wait till the end. Is that okay? Yeah.
Yeah, we'll address your question at the end. Thank you. And final question for Dr. McKee. What policy recommendations can you bring forward that advocates might want to consider?
So in reference to policy, we recognize that that's important. And I'm trying to learn. I was just on sabbatical briefly, and we're focused on disability health policy. I'm trying to help influence change in general. And understand that takes a lot of work. We have to educate, we have to be patient. But I do think it's important to build a network, connect with organizations, a place where we can all come together, whether we're deaf, deaf-blind, hard of hearing, wheelchair user, that we all come together and we're able to collaborate, because oftentimes we're isolated in individual scenarios. And so if we can come together and find a way to work together, I think that's important. We can find different champions that can push open those doors and open other opportunities. I have two groups that I'm working with right now, the AAMC, which focus on credentialing medical students, and the ACGME, which is focused on residencies and fellowships. And I'm trying to collaborate with them, work through our national organization to bring forth that requirement of training for disability, for diversity, just to move forward our future generations of doctors so that they can become more comfortable working with the community, and hopefully they have more cultural respect. We have to understand that not everybody is an expert, that's impossible, but is possible to be open-minded, humble, happy to help and learn from the community. And that's what we do want to see. All right. Thank you.
Thank you, Dr. McKee. Next up, we have Robin Jones, the project director and principal investigator of the Great Lakes ADA Center. Talk to us about non-discrimination in health programs and activities, including requirements concerning medical diagnostic equipment. Robin, please give us some insight into the current issues concerning this topic.
Thank you. This is Robin Jones. I am a in the 60s white female with short red hair and wearing black rimmed glasses, and I'm wearing a white jacket with stripes on it today. Uh, if you think about the ADA, we're going to be celebrating the 35th anniversary of the ADA here in July. And when the ADA was written and the rules and regulations were written around the ADA and what you needed to do, when we look at the environment that we are all operating in and such, it really has been focused on the physical environment more from a structural perspective. So if you look at the standards for accessibility that were developed for the ADA, which were built off of previous standards under 504 and other legislation, it really only deals with the structure. And I always kind of separate the ADA out and its requirements by looking at a building and saying, if I took the building and I turned it upside down and I shook it, everything that falls out is not covered by the ADA because it's not part of the structure itself. So the walls, the doors, the parking, those things are all there because they're part of the structure. So we don't have standards for accessible vending machines. We don't have standards for what an accessible chair looks like for someone who's bariatric. We don't have a lot of equipment type standards. We're just starting to get some of that. And so when you think about healthcare, healthcare is not just about the doctor's office. It's about what happens in that office, which often involves the use of equipment, exam tables and things of that nature. And we have not had standards of what does that look like from an accessibility perspective. So fast forward from the ADA being passed in 1990 and those standards coming forward, et cetera. And we had the Affordable Care Act, which was passed in 2010. Part of this Affordable Care Act, which most people don't know about unless you read it from top to bottom or fine print, is that the U.S. Access Board was charged at that time, and they are the federal agency that is responsible for developing the standards for accessibility. They were charged with developing standards for medical durable equipment, MDE, or medical diagnostic equipment. And they did that, they worked on that, and they released their initial findings in 2017. So even that, from 2010 to 2017, is a pretty long period of time. But in order for those to be part of the ADA or be enforceable, you have to have the federal agency that enforces the ADA incorporate them into the regulations that are enforceable under the ADA. So having strictly a guideline or a standard, which is what the Access Board did not make it enforceable. It just told us what it should look like if you were to create it. Okay. And when I talk about this type of equipment, what I'm talking about is things like an exam table. I'm talking about the chairs that might be used in a dentist's office or an optometrist's office or something of that nature. I'm talking about a weight scale. And I'm talking about like diagnostic equipment like a mammography machine, a CT scan, an X-ray machine, et cetera. That's what we're talking about when we're talking about this medical equipment and it being accessible. So if you imagine somebody who's going in for just regular checkup, like my yearly exam, my yearly checkup type of a thing, and I'm a chair user, I'm going in and, one of the first things that goes in, and it's one of the things I dread when I go into the doctor's office is get me on the scale. And there's many reasons that they do that. Scale weight is used to monitor your health. It's used for dosing of your medications. It's used for a lot of different things. But if they don't have an accessible scale, you're not going to get weighed. And so how are you going to know how much that person weighs? An example might be that maybe I was hospitalized and a lot of the hospital beds have scales on them. So that may be the last time I was weighed 3 years ago, let's say. And now I'm in, and now I don't have an updated weight, and it may impact a lot of different things, right? Because they don't have that access to do that. So what has happened is that we've waited and waited and waited for the Department of Justice, which enforces the ADA, or one of the other federal agencies that have enforcement authority under the ADA to do something. And the disability community was really pushing. Legislators were pushing this. There were numerous letters that were written to the Department of Justice by legislators, by disability organizations like the National Council on Disability, like the National Independent Living Council, et cetera, saying, hey, this is really necessary. You need to do this. You need to do something about this. So fast forward, all right, you have 2010, you have 2017 where you have standards, but they're not enforceable. So what happened is in 2024, towards the end of the last administration, we did see the Department of Justice in July or the end of it, issue the enforceable regulations for medical equipment. And they limited it, however, to only being applied to medical entities owned and operated by state and local government. So that would be a state-owned hospital, a county-owned hospital, a city-owned hospital, a university, medical clinics, and things of that nature. It did not apply to your doc and box, or your clinic or any of those kinds of things. It only applied to those that are owned and operated by state or local government. It did incorporate those that might be operating on behalf of a state and local government. So a lot of times the local government or state government might not have their own clinic or hospital, but they'll contract with somebody else to do it on their behalf. Then it would extend to them because it's a contractual relationship doing it on my behalf as state and local government. But that's how the ADA has played out with the Department of Justice. So the implementation date is October 8th of 2024 that were passed. And so that date said that any new medical equipment that was purchased after that date had to be purchased accessible until they met their requirements for accessible equipment. And the requirements that are set forth in the standard in the regulations are 10% or at least one. If you are an entity that primarily serves people with mobility disabilities, like a rehabilitation facility or a physical therapy facility or something of that nature, the number goes up to 20% of those, or at least one. Okay, so that is the requirement. Then they added an additional requirement that said, irregardless of whether or not you are purchasing, because this is only purchasing new. So if I continue to use my exam tables for the next 10 years, then I don't have an obligation because it's only when I purchase new. So they added an additional requirement specific to two pieces of equipment, one being the exam table and the other being the weight scale, and said that they were given 2 years, irregardless if they were planning to buy new, they were given 2 years to purchase new exam table and weight scale minimally. Okay, so that has been in effect so until 2026 to meet that requirement. Also included the requirement to train staff in how to use the accessible equipment, and also included requirement to train staff on how to transfer and assist people with disabilities to get on and off such equipment. So those are part of the requirements that the Department of Justice has put in place related to that. So shortly after the Department of Justice issued their regulation, Health and Human Services, which is main health agency at the federal level, updated their Section 504 regulations. Now, 504 is under the Rehabilitation Act of 1973, for the youth that are not familiar. It's the section that says anyone who receives federal funds cannot discriminate on the basis of disability in their programs, services, or activities. Each agency writes its own Section 504 regulations. In this case, Health and Human Services updated their 504 regulations and took this opportunity to add some additional requirements into it. So they mirrored pretty much what Department of Justice did, but the difference is HHS regulates a much bigger group than what the Department of Justice does, because remember I said Department of Justice only applies the regulations to local and state government. With HHS, theirs is anyone who receives or accepts Medicaid, Medicare, or any other funding from HHS. Now we are starting to talk about doctor down the street, the clinic down the street, privately owned and operated, if they take Medicare or Medicaid dollars. So it starts to touch on that private sector because of that particular requirement that is in place. They put in the same requirements for 10% and 20%. They also are using the same 2-year deadline for the purchase of scale and exam tables. So pretty much mirrors. It's their difference is who it applies to and the enforcement mechanism in relationship to that. So these are very important regulations that are in place. We do know that there are some challenges right now in the federal world that we don't know how this will all play out. Again, these regulations came out right at the end of the last administration. And we know that there's a lot happening in these agencies going forward right now. We know that HHS has going through huge transitions. We know that, for example, you are in Region 5 of the Health and Human Services, if you didn't know that. And your Regional Health and Human Services Office of Civil Rights is in Chicago. I should say was in Chicago. They've closed it. So there is not a Region 5 Office of Civil Rights right now for HHS. We're not quite sure where they've reassigned it. They have not publicly told us where it's been reassigned. So we're not exactly sure. We know that the civil rights, disability rights section of the U.S. Department of Justice has been dismantled. There is no longer a disability rights section as we know it. The leadership and the staff are gone. They have been reassigned or have terminated and or resigned themselves and left. So we don't know, even though we have these regulations in place and they're in effect, we don't know what the enforcement mechanism is going to be for it because of all of the things that are kind of up in the air right now related to this. But we're trying to do the best we can to educate our providers about this obligation and their responsibility, and hopefully things will move forward. So again, it's following the established standards that are there, which talk about height, minimums and maximums. It talks about clear floor space around it for a wheelchair to be able to maneuver. It talks about signage or instructions being available verbally in multiple means for people who might be deaf, hard of hearing, different sensory disabilities, et cetera, et cetera. So the technical standards are solid. They're there. They're well known. It's really now the implementation that we're really dealing with in this scenario. So just again, imagine that person who goes for that physical, and they're not able to get weighed. This is very common. This is very typical. They are not able to get up on the exam table because it's not accessible to them, which means that their skin's not monitored and checked. Their, potential other health issues are not looked at because they can't get up on the exam table to be fully examined. And it's difficult to examine in a chair. You don't get to see everything related to that. I'm not going to get my mammogram because it's not accessible to me. So my detection for cancer or anything might be greatly delayed or only relying on manual palpation, which doesn't always pick up things until later in stage 2 or 3. And that gives me a lesser health outcome. And this is very, very common, unfortunately, for people with disabilities, specifically physical disabilities that have difficulty using this kind of equipment that's not accessible. So we're hopeful for a different world with these regulations, but there's a lot of unknown right now. Some of you may be aware of the fact that there is a lawsuit currently that is challenging Section 504 regulations that were released by HHS last year in August. Part of that, again, if the courts were to rule in favor of the lawsuit, which would be to basically withdraw those regulations that were issued, that would include this provision for medical as well. It doesn't impact the Department of Justice's, but again, remember, Department of Justice is limited in scope to only Title II entities. And so that HHS ruling is really important because it expands it to that private sector that is a recipient of Medicare and Medicaid as well. So.
This is Brendan speaking. For all of us watching this all unfold, and we want to be part of the solution, what can be done, at all levels of society to try to increase equitable access to healthcare for people with disabilities?
Well, again, I think it's we need to be more vocal and demand more of our healthcare providers in relationship to this issue. We are all the ones who are recipients of these services. We are the ones who are working for a company that is providing healthcare, that is providing insurance, and we need to be vocal to our employer about the fact that we need to make sure that they're using a policy that's paying for these things and that is demanding it of their providers and such. We need to be vocal to our legislators and such in relation to these particular issues. Um, let them know we need to be speaking about the fact, do not um, do away with the enforcement mechanisms that are necessary, because unfortunately we are the police, each one of you and us. We are the police. There's nobody proactively doing this, so we have to demand it of our healthcare providers. We have to educate ourselves about what's required, because we're probably going to be having to educate our providers about what's required, because I always say rules and regulations and laws are only as good as the piece of paper that they're written on. It's how they're enforced and how they become part of the everyday life and operations of organizations that make the difference. So we really need to think about that, aggressively, et cetera. Also, from a policy perspective, here I use Michigan as an example a lot. I cover 6 states: Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. And I use Michigan a lot because you have continuously modified your laws at the state level to mirror or exceed a lot of the federal laws. So that if tomorrow a law at the federal level was to be struck down, somebody would still have protections here in Michigan at your state level that would be substantially equivalent to that. And so looking at how can we strengthen, or how can the state of Michigan's laws be strengthened, irregardless of what might be happening at HHS or what might be happening at Department of Justice in regards to looking at these issues and incorporating them into your state law from a policy perspective, from an architectural perspective, from your public health, when they're licensing these medical clinics and things of that nature, and then providing a mechanism at the state level to be able to file a complaint if I don't get what is necessary and needed. So I think that these are something that Michigan needs to look at, and I know they do because they have done a lot to keep in pace with what's happening to ensure that again that there's at least equal, if not higher, level of accessibility. And that's something that you can do by really making it known to your legislators and such that you want that you want Michigan to be a leader in this area. You want Michigan to provide you with a local remedy, not having to always have to go at the federal level, which may or may not um, be successful.
Thank you so much. Our next speaker is Michelle Roberts, the Executive Director of Disability Rights Michigan. Michelle's going to talk to us about accessible healthcare with a focus on mental health care access, affordability, and quality of care. Michelle, tell us about an issue that you've commonly observed when it comes to accessible healthcare and the potential policy implications.
Thank you. Good afternoon. This is Michelle speaking. I am a middle aged white woman with shoulder length, dark brown, curly hair. I am wearing a black suit with a floral top underneath, and I will be using my cheaters to read my notes. So, I'm going to tell you about a scenario that we see frequently, regularly. And it's regarding an individual of any age, child or a grown up, who has a mental health or behavioral health needs, and they find themselves in a crisis, having a mental health crisis. And they either present to the emergency department on their own to ask for assistance, or perhaps law enforcement has been called to intervene, maybe by a family member or a neighbor. There's generally three things that we see happen. One is the individual's assessed for their safety and risks, and it's determined that they don't require inpatient hospitalization. So they're released with a recommendation that they follow up with their local public mental health provider, which in Michigan is community mental health, or their private doctor if they have private insurance generally. The problem with that is that there's a lack of ability to access behavioral health services in their community because the public mental health system is difficult to navigate, and it provides different services, though it isn't supposed to, in different areas around the state. So if you're in one county, perhaps you have access to this array of services. If you're in another county, perhaps you have an array, access to a different array of services because of provider shortages and other factors. There's also a lack of home and community based services that are available in the community, which is largely linked to the lack of direct care workers, the shortage that we have here in our state and also across the country. That that ends up impeding people's ability to, even if they're authorized to get those services, to actually get them because there aren't a lot of staff to provide those services, which I'll talk a little bit more about later. The second thing that we often see happen in this scenario is that the individual is held and ultimately they're petitioned into the hospital for inpatient psychiatric care. That becomes a challenge when it's time for them to leave. They've reached a level of stability or recovery where they can and want to rejoin their community, but there's a lack of coordination and planning for aftercare services and supports to help them remain stable and healthy in their communities, which can cause a backlog in the hospitals for people who are in the emergency departments wanting and needing to have that level of care in the hospital. The third thing that we often see is the individual remains at the emergency department for an infinite or indefinite period of time without being assessed, without being treated, and they're waiting for potentially a month or longer while they await coordination of services, either in a hospital, inpatient setting, or in the community. Which again, same kind of challenges with those first two sort of ways that we see this work out. In addition to the fact that there's a major shortage of psychiatrists in our state. And so we tend to refer to this as like a hamster wheel situation where People can't get the services that they need how and when they need them in the community, which then can exacerbate or bring on symptoms. And so, particularly with mental health, some of those things are fluid, but the service system isn't nimble enough to adjust and adapt to provide the services how and when the individual needs them, which then, as a crisis happens, they present to the emergency department and then they sit there. But then there's a backlog because they can't get into an inpatient setting if, in fact, that's what they need, because there's people stuck in inpatient who can't get coordination to get the services to get back to their communities, and so on. And so it's this vicious circle that kind of happens and self perpetuates itself. So that's a common scenario that we see with a few different ways that we see that play out here in Michigan.
This is Brendan speaking. There we go. Cool. That's Brendan speaking. So, for those of us who are here who want to get involved, what can we do at all levels of government to do something?
There's a lot that folks can do. This is Michelle speaking again. One is have conversations with people that you know about disability, including mental illness. People tend to not be aware of things that they don't believe to be a part of their world. So if they themselves or they don't have an immediate family member that has a disability or something that actually is identified as a disability but they never thought of it that way, that's when you get that othering that happens of, well, that's their problem, that's not my problem. But when people start to learn and realize that all four of us up here identify as people with disabilities and that we're your neighbor. I'm the lady you sit next to at church. I'm your coworker. I'm the gal that's in the grocery store line behind you. It's everywhere. And that's when people start to, there's less of the less thans, the othering that happens because you're now my neighbor, you're my friend, you're my colleague, you're my partner. So that's one thing. Another thing is to talk to your elected officials and people who make decisions about policies and laws that affect all of these kinds of things that we're talking about throughout today. One thing is Medicaid. Medicaid is under attack, and there is a massive impact, negative impact that will have on every single one of us here, even if you don't even if you aren't a Medicaid recipient, even if you don't use Medicaid for your health care. If something happens with Medicaid and there are massive cuts like what are being projected, that harms all of us. It harms all communities. So contact your elected officials, contact people who make these decisions and tell them why it matters, why it's important, how it will affect you. The personal stories that people are hearing here in Michigan and in the Congress who are here, who were elected to work for you, those personal stories are making an impact. It is getting people's attention because they don't realize that when they say, we're going to cut Medicaid, we're going to reduce Medicaid by this much, they don't realize everything that that covers. And just yesterday, we got some information, some statistics from our State Department and our governor. 2.6 million people in Michigan receive Medicaid. That is more people in Michigan than the entire state of New Mexico, more than the entire state of Nebraska. Think about that. That's a huge number of people. And so when you think about all of the things that Medicaid covers for people in Michigan and how it enables people to live in their homes, to stay in their communities where people have better health outcomes, it's more affordable, it's more effective, it's more desirable. Why would we not? Why would we not want to preserve that? So tell the people who can make those decisions why that's important. Another thing is we need to professionalize the direct care field. If people are going to live in their homes and receive home and community-based services and supports that help support and promote them in their communities and their homes, we have to have staff to do that. And in order to do that, people have to be able to earn a living wage. If I can't take care of myself and keep my lights on and pay for my medication and food, let alone for my family, I'm not going to take that job, even if I feel like that's where I'm really meant to be working. Because at the end of the day, I've got to be able to take care of myself and my family. And so if I can go to a local retailer or a fast food store and get a higher wage, get health insurance because I have medical needs, and even potentially have opportunities for advancement and to further my education, I'm going to be forced to take that job. And so we have to be able to professionalize that field. Related to that is also promoting psychiatry. We have a shortage of psychiatrists, and since I was asked to talk specifically about mental health and behavioral health, that's why I bring that up. And hearing Dr. McKee talk about some of the forward thinking things that the University of Michigan is doing by being deliberate in teaching medical professionals and people who are seeking to become medical professionals about disability. Wow, that's mind blowing, right? Like that's a given that should have been happening, but it isn't. And the same thing needs to happen with psychiatry. People need to see that this is a valuable profession, and then they need to be paid enough to want to come in Michigan and stay in Michigan to help treat our people in Michigan who need those services. The last and final thing I will say is we need to reform our public mental health system. Our behavioral health system in Michigan is complex, multi layered, complicated, difficult to access, expensive, and there's very little that ends up going to the individual who needs the services, which again perpetuates that hamster wheel circle that I mentioned earlier. And so we need to eliminate the conflicts of interest. We need to remember what the public mental health service was created for in the first place, to serve our most vulnerable citizens and serve them. Thank
This is Brendan speaking. Lastly, we're going to hand it over to Representative McDonell to talk about some of her experiences and some legislation that's going through.
Good afternoon, everybody. I'm Sharon McDonell. I am a state representative and I represent House District 56, which is mostly Clawson and Troy in Oakland County. Um, I am interested in this topic because I've had a kind of a moderate physical disability most of my life. At 4 years old, I was diagnosed with rheumatoid arthritis, um, which there aren't a lot of kids with that. But in terms of what it has done throughout my life for healthcare access is my parents were often denied healthcare insurance at the workplace because the insurance companies before ACA knew how expensive it would be to take care of me and they didn't want to. So that was a problem all the way up until um, I think 2009 when ACA came out. Um, I have experienced also, um, my daughter was temporarily on Medicaid. A lot of people really don't understand Medicaid when we're not together in this community. I try to explain all the time to people who don't have personal experiences with it, the various ways it can be used, because I'm so worried about it being cut drastically. Um, my younger daughter, when she was a teenager, she's fine now. She had cancer, and Medicaid took over as her insurance, helping us help her get better. And just about a month ago, she was diagnosed with being on the autism spectrum. So now she is actually, we found out that she was eligible for Medicaid, but that's coming at a time when Medicaid is under grave danger of being cut or worse. So all of these issues are very important to me. In Lansing, I'm the chair of the Michigan Legislative Disability Caucus. We also call MLDC. We've had a lot of help from Brett Williams of the Michigan Developmental Disabilities Council. Our monthly meetings include legislators, um, not just legislators too, but self-advocates also, like Jeannie back here, um, who's almost at every single meeting. Um, and subject area experts, educators, family and loved ones, and service providers. We cover subjects like housing, rights in education, education to work, transition services, guardianship issues, and a whole array of other things. You can reach out to my office and we can get you signed up. We have virtual meetings every second Monday of the month at 1 p.m. So everybody can be part of it. What we do is we're working to identify legislation that can make life better for people with disabilities. Um, in my first term, I sponsored the upgrade of the My Able savings accounts in Michigan. And also, I sponsored and we passed Justice for Alley legislation, which, if you haven't heard of it, it made, imagine this, it made online sexual exploitation of vulnerable adults illegal because it wasn't before, because only children were protected and now adults are protected as well. Um, I'll talk about some of the legislation that I am sponsoring and working on, and some that I support. There's one bill we're working on called Everybody Can Move, and this legislation would require insurance to and Medicaid to cover prosthetic devices. This is usually for people with missing limbs. And what it does is it takes a step past just giving a child a generic prosthetic limb so that he or she can walk to class, but also supplying them with more active equipment so that they can actually play on the playground and run and stay healthy. And that's also for adults too, of course. We haven't introduced the legislation yet. We're working on it. Um, and hopefully we may be able to pass it this term. Another thing we're working on is the Motorized Wheelchair Users Bill of Rights. When motorized wheelchair users wheelchairs break down, I hear. I haven't talked directly to anybody, but it often can take weeks before the manufacturer will send someone to fix it. And if the user of a family, the user has the ability to fix it themselves, the manufacturer may refuse to provide them with passcodes or other digital tools that are necessary to fix it. So this is made all the more difficult when insurance companies require you to get a new prior authorization or prescription before they'll pay for repairs. So we're trying to streamline that process and help people. If mom or dad is really good with their hands and they can fix it, let's let them fix it, save money, save time, and keep people moving. Um, there was some talk about Section 504, since that is a problem. There are 17 states that are suing in Texas um, to um, overturn Section 504. And that's a huge problem. It could take away a lot of our rights. So um, we are trying to codify it, protect it in the state of Michigan. Disability Rights Michigan is helping us work on that. There's some confusion over whether it's already safe and protected in the state of Michigan or if we need to do more and have some legislation to fix that problem. As you may know, that the 17 attorneys general in this in states are suing because they, the lawsuit was motivated by our past president interpreting Section 504 to include gender dysphoria. And while the attorneys general, and that's a very obviously a hot political issue, but those attorneys generals that are suing to end 504 refuse to take out, um, refuse to just erase that those words in it. They want to overturn the whole thing. So that's a really big problem. And we're working hard on that. And any of these issues, if you have information and would like to help our office work on these, please contact us. And we are always willing to share um, our drafts with people to get other interpretations and information. The final thing that we are working on is a lot of people are concerned about 14C certificates or what what used to be called workshops and sub minimum wage issues, all kind of the same thing. Um, it's a pretty also controversial issue, but I think one of the things we do know, the way I look at it is what we do know is it is going to be probably overturned sometime soon. So maybe it's less important when it's overturned and more important that we make sure that no one loses um, no one loses the social opportunities and work opportunities that they have that families have come to rely on. And we find a way to make sure that the transition from that is good for everyone and that people are not left out, people are not left at home. Um, and finally, there's one other piece of legislation that's meaningful to me. It's the PDAB, is what we call it, the Prescription Drug Affordability Board. And the idea of it is it would set up a board that could um, have the power to analyze the cost of drugs in the state of Michigan and to work on lowering prices and to work on capping prices of some medications. As I said, I have rheumatoid arthritis. I take Enbrel, which is one of the most expensive drugs. It's about $8,000 a month. I don't have to pay that because I have good insurance. If I didn't, I would have zero access to it. Um, so that's important to me. And I think, well, I did also mention in this morning's session that when we talk about policy, as we know, one of the biggest places, one of the biggest events in the state every year is the MacDonell Policy Conference. And I just want to say that it concerns me. It's very hard for me to go there. I don't think I'm going to go there this year. I got a new knee last July, and it's very hard, very inaccessible for all of us, I think, to go there, to get there on the boat, to get around with no electric vehicles, no gas powered vehicles, just horse buggies that you have to climb up into, and a lot of stairs, a lot of grandfathered in buildings that don't have elevators everywhere. So I just think that that's something concern to me, and that maybe, that's where everybody goes to set policy, including the governor and all of the legislators. So if people with disabilities are excluded from attending, then maybe we're not having our voices heard and we're not getting our policies considered. So s- I'm going to look into kind of seeing if they can make it more accessible. But that's all I have. Thank you so much.
This is Brendan speaking. I want to say thank you so much to all of our presenters. They did an amazing job. Next up, we are going to turn it over to the audience for Q&A. So we will have ASL interpreters going around as well as a microphone. So just raise your hand and let them know that you're ready to ask a question and we can address the panel.
I have one suggestion that might work. Maybe if you craft some sort of book with a bunch of groups that you can pass out to different patients in different doctors' offices to sort of help spread the word and educate people about all of their options. Because a lot of us carry this daily burden of educating everyone around us, and that's not fair to us. So rather than us always having to educate, maybe creating some sort of pamphlet or book that we can then disseminate to different clinics, or you all can disseminate to different clinics and hospitals. And that might be something that's more effective rather than us carrying that daily burden of education. I know it helps us to help teach, of course, but it shouldn't be solely a burden that the disabled carry. Just a suggestion.
Brendan speaking. Thank you. I also have another question that was handed in. And the question is, we, the deaf, are frustrated with video relay interpreters in hospitals and not having live in-person interpreters. Where is the enforcement to have live in-person interpreters in hospitals?
This is an issue that is widespread because it is kind of by default. A lot of medical facilities found it easier. I'm sorry, this is Robin Jones speaking. Um, find it easier or less, I don't know, to use the video interpreting than to have on staff interpreters or on call interpreters to come. Another problem that we experience and I'm in a big city in Chicago, is a lot of post COVID, a lot of interpreters don't want to come out in person. They prefer to do remote interpreting because um, they can go from job to job without travel and things of that nature also. So we really struggle getting in-person interpreters for events and things because there's less interpreters who want to do that and are available to do that. So there's a shortage of interpreters in general, and so that makes it difficult. From the regulatory perspective, the requirement is what's called effective communication, which there's a responsibility to make sure that the communication with the individual is effective. And it's the agency or organization's responsibility to provide that and to make an argument of why they provided one method of communication over another and that it's equally effective. And that's a huge challenge that people fight, you as individuals with disabilities fight, is your argument is it's more effective for you to have an in-person interpreter, and the entity is making the argument that it's equally effective to use the video. And I mean, there's a huge difference in just in the work that I do, and I'm sure those of you that experience it, that providing video interpreting when you're in the emergency room laying on a gurney and can't see well, and the connection uh, of the interpreter or the screen, and such is not good for you to be able to view and to be able to interact and such because there's so much going on around you. That's definitely an argument of not being effective. Whereas an in-person interpreter who's able to read the room, is able to negotiate all of those things, makes a big difference and such. And so this is an ongoing struggle and an ongoing issue that I don't think there's a great answer to, and whether there is, but it continues. I think we need to continue to press and work with our um, medical providers about what truly effective communication is and identify where video is appropriate and where video is not appropriate, and not be a one fits all kind of um, uh, scenario for them. There's a lot of work that still needs to be done in this area. So again, video is great when it's effective, but it's not always effective. So
This is Mike here. I just wanted to add, we have a deafblind community struggle with this as well. We have RID, which is an organization that has some information on there where, situations where we don't recommend using the VRI and some specific guidelines on when to use. So there's recommendations on both and really just in a more neutral stance. Sometimes there is no interpreter available. And so if it's effective, is that fine? But clearly there are some scenarios where that's not as effective. And so, maybe if we have, we had a deaf mother who's forced to use a VRI during a private moment such as labor, um, and might be awkward in situations like that. So there's obviously other situations where we wouldn't use the VRI in those situations, but that's a great question.
This is Brendan speaking. Thank you so much for the question. We have another written in question from the audience who asks, why are there no mental health hospitals in Michigan providing services to deaf, deafblind, and hard of hearing inpatients? And I suppose I'll tag onto that. What can we do to fix it?
This is Mike again. There's a huge need for mental health services with our deaf, deafblind, and hard of hearing communities. This does require cultural competency, language communication. We know that there's a knowledge gap there. We have to navigate through that. Especially, it takes a special training, and some states in the U.S. do have focused trainings that they provide. For example, Massachusetts, Alabama have those trainings. We do not have that here. And so I am struggling myself just to find those trainings. I have patients that need specific counselors or mental health services. We do have Deaf Can, which is an organization that provides some of those services. But to be honest, my list is rather short. There's four agencies around the state that use signing as their mode of communication. It's a very, very limited list. Some of those resources don't accept Medicaid. And so then we have another barrier. And sometimes we have to work with them and try our best to figure out how to best accommodate that. We're definitely lacking in that area, and we definitely need more support to maybe pay for some specialized training within that area. Anything else to add? Okay.
This is Brendan speaking. Do we have any additional questions from the audience?
Good afternoon. My name is Tanika. I am a civil rights investigator for the Michigan Department of Civil Rights. And I just wanted to, I didn't have a question, I just had a comment. Ms. Jones had mentioned um, what the DOJ was doing in terms of making sure there's accessible equipment. And I just wanted to point out that under the, PW DCRA 1976 here in Michigan, if you if a patient is requesting an accommodation prior to um, going to their doctor's appointment, um, and the equipment maybe doesn't fit them, and they've already identified that, they probably could potentially file a complaint under unequal service with the Michigan Department of Civil Rights because you've made them aware. This probably wouldn't be something that you would file a complaint on if there was like an emergency, if you went to the emergency department. But if you were asking in advance, then they're well aware of what the needs are and they should be doing what they can to make a reasonable accommodation. So I just wanted to share that.
This is Brendan speaking. I believe we have a question with a microphone in the back.
My name is John, and my question is, why is it that there has not been an effort to set a lot of these things in law? I mean, that's the only way in which we can force the system to react. And we all know that these issues are very, very hard. I think it's time for us to consolidate our efforts in trying to put things in law and make certain activities mandatory. Let me give you an example. There's no reason why a doctor is going through 4 years of medical school without some type of clear orientation in working with people with disabilities. Now, from time to time, certain medical schools and even some universities have had individual classes where they had the insight to invite people with disabilities into their class and speak to certain type of issues. There is no reason why this cannot be mandatory for doctors at all levels. There also can be efforts to mandate that the medical profession respond directly to accommodations. I guess what I'm trying to say, I'm sick and tired of hearing people talk around the issues. If you're gonna fight, let's take on the fight. Let's quit playing the game. It sounds good. We need to deal with this head on.
This is Brendan speaking. We only have a couple more minutes left for questions. I did get a couple in writing. So the next one was, is there a way you can think of or have seen to make the hospital or ER services fast and accessible at the same time.
I can't answer that. That's
Stumped.
it's a good goal. I don't, yeah, stumped.
This is Brandon speaking. We do have another one. Can you elaborate on disability awareness training for all medical personnel? You mentioned only 0 to 8 hours. Who would be the regulatory agency for that?
Can we talk about state law?
Talk about whatever you want.
Yeah, go ahead.
Oh no, no, I meant let's talk about doing it in state law.
Just want to make sure. Okay, can you see me up here? Better? Good. So there's two recommendations to help enforcement. And I mentioned the AAMC, that's the medical college credentialing system. And we also have the ACGME, which involves residency and fellowship training. The ACGME is a little bit behind. They do recognize that there's a need there to require all residents and fellows to have a focus, and this is specifically in primary and family medicine, focus on disability areas. So they've made a commitment to move forward on that, which helps with that requirement. The AAMC's already started moving forward with that. And there's some of my colleagues work within that, and there's some expectation that that's moving forward soon within the colleges. Is the same for nursing programs and therapy programs. I'm not familiar with that, but there is some enforcement occurring, and if they don't follow those recommendations, they have risks of losing their credential in the future. So we're hoping that that helps with enforcement as well.
This is Robin. I just want to add, I do a lot of work with medical facilities and things like. It's not just the doctors. It's not just the therapists. It's the receptionist that checks you in. It's the person who takes the phone call to schedule you, who doesn't know what a sign language interpreter is, or doesn't know about captioning, doesn't know their policies and procedures for even in the intake of reasonable accommodations and such. So it really is wide reaching in regards to everyone that works within these facilities. I myself am an occupational therapist, and I know I didn't get much at all, even though I work with people with disabilities in the treatment. It's very different to treat somebody than it is to interact on a regular basis with somebody, because in your therapy, you're focused to fix the situation. You're not always focused or taught how to interact in this situation. And I think there's across the board, this is an issue. Anyone, I don't care, even the dietary people, even the person who's cleaning your room, when you're a patient and stuff, they need to be doing and be mandated to do disability awareness education across the entire institution, it's not just the doctor, it's not just the nurse, et cetera. It's everyone who works in these settings needs to have this education, because you probably are going to interface with them more than you're going to interface with the doctor.
This is Brendan speaking. Unfortunately, we reached the end of the time for our panel. I mentioned earlier that we wanted to end the session with 2 to 3 policy recommendations. I believe we had a lot more than that. um, we had staff taking notes to capture any of our practical solutions that we discussed. These policy recommendations will be reviewed by the Civil Rights Commission, the Civil Rights Department, and our partners to drive change in the state of Michigan. We'll now have a 15-minute break before the closing plenary begins in the main plenary area. Feel free to walk around the exhibit tables. We have organizations that want to share resources or information about what they accomplish. For those that may be feeling a little overwhelmed, we do have a sensory room located on the first floor of the venue. Just look for a sign or ask a member of staff. Thank you for joining us, and let's get a huge round of applause for everyone.